I mean, the first slide, which is typically my starting slide, is why should we actually look on regional information. This already has been discussed both by Nader, Habashi, and Ola Steinquist quite extensive. So my point here on this slide now is only if we want to maintain lung protective ventilation. I think that much is, I think, clear. We have to avoid effects like especially tidal recruitment, but also collapse, permanent lung collapse, are certainly regional effects. And of course, to display regional effects, it's good to have not just regional information like from a chest X-ray, but it's much better, can be seen these different regions and this different behavior in a transversal projection like a CT scan. So if we first took a look on a CT scan, this is also something Ola mentioned in his presentation. CT scan shows air content, right? And so we don't know exactly what happens with the dynamic process of the ventilation. But we would assume that in a healthy lung, more or less all parts of the lung will have a similar compliance. So we would assume that we also see normal ventilation throughout the lung. Now with EIT, we are not showing the air content directly, but we are focusing on the changes of the air content. And we are always, if we talk about changes, of course we have to define what is our reference point. And we chose to take as a reference point always the end of expiration. So no matter how the real impedance is, because it's called impedance tomography, we are just setting all the pixel values at the end of expiration to 0. And so we are looking what happens during the inspiratory phase when the impedance starts to increase. And fortunately, there's a pretty linear relationship between the increases of volume and the increases of impedance. At least in the one single patient, that is true. So the color scheme in our images are black shows no ventilation, because at least if it remains black at the end of inspiration, then there's no ventilation taking place. And that might be due to various reasons. It could be because the spine is located here somewhere, or the mediastinum. But if something where we would expect to see lung tissue is remaining black, then it's probably due to, for example, collapse. But it could also be that due to massive overdistension, the compliance also goes down, which also could lead in a very extreme case to a non-ventilated region in the ventral parts of the lung. Blue color means there is ventilation taking place, and white color means there's the most ventilation taking place. So some people have mistaken the white color as overdistension. That is not true. It's the regions with the best compliance actually. And I mean, both techniques, computed tomography and electrical impedance tomography, are both called tomography, but they're not really twin brothers. As I said, the first one is CT displays air content, and we display changes of air content with the EIT. And also the slice thickness, for example, is completely different. Typically, one single CT scan represents 2 to 10 millimeters slice thickness, depending on the setting of the CT scanner. And with EIT, we are rather capturing a lens-shaped volume, which is at the surface of the body defined by the dimension of the electrodes. In our system, we are using a belt with a thickness of 4 centimeters. So the slice we are capturing is at least 4 centimeters. Towards the center of the thorax, the slice is actually increasing, because in contrast to the X-ray, which is really going straight through the lungs, the electrical current always looks for the easiest way to pass through the thorax, and that's why it's spreading like an electromagnetic field through the thorax. I will come to that point in my second presentation. Also, we are displaying with EIT functional information, while the CT scan is displaying morphological information. The temporal resolution, of course, in a CT it's just a snapshot, and with the EIT we can produce up to 50 images per second. So it's a very high temporal resolution, while the spatial resolution is much less compared to a CT scan. Now, when we capture an inspiratory screen, which we call the tidal image, we can subdivide this into the ventral, mid-ventral, mid-dorsal, and the dorsal region. And these percentages might not look exactly the same like in Ola Stenquist's presentation, because of course it's depending a little bit where exactly you put the belt. If you have the mediastinum located here somewhere in between, then probably the portion of the ventilation and the ventral and mid-ventral region is a little bit less. Okay, so this is a healthy lung. Now when we see a typical CT scan with a dorsal collapse, we would already assume that whenever you have some consolidated lung tissue or collapse, atelectasis here, there's no lung volume. That's what you see in the CT scan. But at the same time, there's of course also no ventilation taking place. And in a typical EIT image, this lung region would simply remain black, and the corresponding percentage would probably go down from 10 to 15% down to, in this case, 2%. So everything that is less than 5% could suggest already that probably the dorsal part of the lung is not fully opened. Now when you see this kind of inhomogeneous distribution of ventilation, then of course it could be worth to try to change this and to improve the homogeneity of the lung. And if you're successful with doing that, then you would probably immediately see breath by breath that this dorsal percentage would increase. However, if it's a non-responder, we have talked about pulmonary and extrapulmonary ARDS, then you might induce a situation where you have at the same time ventral overdistension, which also reduces then ventilation, but the dorsal part remains collapsed. And the typical pattern of an EIT could look like this. Still, you have very little dorsal ventilation. You have also reduced ventral ventilation right now, and you can say that's a classical baby lung, that most of the ventilation only happens in this little part of the right lung. And that is exactly the information that can be displayed with EIT. Also very important to mention, EIT is actually displaying volume information. So this was a recent study where they actually have compared EIT tracings with body plethysmography. And they have also done it in 3 different planes. And what they found is, depending on where they put the plane, of course the ratio between the tidal volume and the impedance changes is different. Because in some planes you have captured the mediastinum, and in others, when you're going to the very upper part of the lung, you don't see the mediastinum right here. So the ratio actually changes, and that is one of the things you have to keep in mind when you're using EIT. It depends where exactly you put the belt. But what can be clearly displayed is that the shape of the tracings from the body plethysmograph and the EIT looks exactly the same. It also has been validated against spirometry. That was a study from Ola's group that has been published. And if I remember right, also in this study, not just the ventilation distribution has been validated, but also the correlation between changes of end expiratory lung impedance. That's what ED stands for, against the end expiratory lung volume. And of course, also very important to validate if there's global information that we can easily validate against the tidal volume or spirometry. If this global information provided by electrical impedance tomography can also be properly translated into regional information. And that has been also demonstrated in at least one clinical trial and also in a number of experimental trials. So how does this electrical impedance tomography work? So first of all, as already mentioned before, the bioelectric properties of the lung tissue change with the air content. The higher the air content, the higher is the thoracic impedance. And that is not directly caused by the fact that air is such a bad conductor, because the electrical current would never go directly through the air. But you can imagine if the lung tissue is stretching a little bit during inspiration, then the tissue around it, the pathways are getting a little bit longer and also thinner. And that is actually what increases the impedance. Can also be, that's also a possible explanation that some fluid is maybe dislocated, and that also might contribute to an increase of impedance. Then we have an electrode belt with 16 integrated electrodes that we put around the chest. And then we always use one electrode to inject a current. In this example, this is this position here. And then we are measuring the resulting voltages around the chest. So with one location of the current injection, we are creating 13 voltages. And then we repeat the same thing at a different electrode pair, and very quickly rotating around the body, doing that. And after one complete rotation, we have collected 208 voltage measurements that are used to reconstruct one signal image. And the entire process of creating this image only takes a short time, like 20 milliseconds. That's why we actually can display these impedance changes as a dynamic image. As I also mentioned, we have, because we are just focusing on impedance changes, we always have to define reference points, what we call the baseline. And that the baseline, that is a point where all the pixel values of the image are defined as 0. The corresponding color is black. So when we see some increase of impedance during the inspiration or due to inspiration, then if you inject the current here, the resulting voltages, or the increased impedance, would cause an increase of voltages at those electrode pairs which are located behind this area. But then we couldn't tell, is it just this area, or is it maybe a small area with a strong impedance change, which is located here, or a large area with a rather small change of impedance. That all would lead to the same increase of impedance here. For that reason, we have to change the perspective on the thorax, so we are going around the thorax, and that's why, which is creating then 16 different voltage profiles. It's somehow comparable, for example, to a 10-lead ECG. Not in every ECG trace you can see an elevation of the ST segment or the myocardial infarction, and that's the reason why you also have more than 2 ECG electrodes. Now, if you superimpose these voltage profiles above each other, then you can see how stepwise the information about the local information about the impedance change is reassembled and reconstructed. And if you do some filtering, you are getting a somehow blurred image. So it's not as precise, as I mentioned before, like a CT scan, but it definitely shows you the region of increased impedance or increased lung volume at the right spot. The way we are presenting this on our device, on the Pogo Vista, first of all, we are displaying continuously, no matter how high the tidal volume is. We don't require any kind of recalibration for that. We are continuously, like a monitor, displaying the changes of lung volume due to ventilation in this dynamic image. And if we plot all those impedance changes over time, then we're getting the so-called global impedance waveform. And the pattern of this waveform looks exactly like the volume waveform of the ventilator. Except when you see some changes of lung volume in the ventilator. All types of ventilators that I know would then zero the volume waveform. So in the volume waveform, you never see any kind of offsets due to changes of lung volume. And that's what can be displayed in these impedance waveforms, as we have seen already in Ola's presentation. Then if you create a differential image between end of inspiration and end of expiration, you can display the end inspiratory status, which basically reflects the regional distribution of the tidal volume of the last detected breath. And then you can subdivide such a tidal image into different regions of interest, as we call it. You could either arrange it as horizontal slides, if you really want to look at gravity-dependent effects. You could also, if you want to look at unilateral diseases, you could also subdivide such an image into quadrants. And then for each of the regions, it's always 4, we would get a corresponding regional impedance waveform and also corresponding percentages that express how much of the total tidal volume, which we have here normalized to 100%, will be distributed into the different parts of the lung. Then we also have, then we also have a trend view. There we have a global impedance waveform, just a global one. And then we have 2 cursor positions that we can navigate through the displayed data set. And then for each of those cursor positions, we're getting a corresponding tidal image and a differential image. And this differential image shows in light blue color when the cursor position 2 receives more ventilation. And it's displayed in orange when here you have less ventilation compared to the cursor position 1. Then we also have a trend table where we can compare directly the percentages for the quantification. And if we have connected a Evita ventilator, then we can also display the data, the measured data from the ventilator. Then, because I've said we are focusing on lung volume changes. And I mean, the one change is typically when ventilation is taking place, that is changing the lung volume, that is what we know as tidal volume. But the second one is when, for example, we increase the PEEP, we increase the force that keeps more air inside the lung, and then we always have an increase of lung volume, but we don't know where exactly this increase will happen. Maybe we just further overinflate lung tissue that is already ventilated, or we have real recruitment of collapsed parts. And so we can display these kind of offsets in the curves. However, we do not have the information about the FRC. We don't know how much lung volume do we have in milliliters. The only information on the volume that we have in milliliters is the tidal volume. And the way we are expressing these kind of changes of lung volume is we are looking at the one cursor position on one particular breath. And if this breath is corresponding, like in this example, to a tidal volume of about 400 milliliters, and then we see after a recruitment maneuver, we get an increase of lung volume, which is represented by this offset here. So the lung volume increase is the same magnitude like the tidal volume at this spot. In this case, we would get one displayed in this dedicated view, which is just focusing on lung volume changes of the end expiratory lung volume. And then this would mean this recruitment maneuver has led to an increase of FRC about 400 mLs. And then the way of comparing the cursors with each other is the same, like in the other trend view. And before we go for another break, just let me maybe demonstrate you one clinical case. That is a patient from a clinical study that was performed, 1 out of 40 patients, after cardiac surgery, all with healthy lungs, so I would say they all had like extrapulmonary conditions. But they have not used EIT to optimize the PEEP. We don't know if optimization is the right term anyway, but they have not used the EIT to set the PEEP. They have rather used the dynamic compliance from the ventilator for that. They basically looked, when we do first a recruitment maneuver, then a decremented PEEP trial, going down in steps from 14 down to 6. Where's the point, or where's the PEEP when dynamic compliance starts to decrease? And that was, in this example, only at the PEEP level of 6, so they have set the PEEP to 8. Just keep it in mind, because now you see what happens with a ventilation distribution. The first task, and this is the first kind of example how you can easily use electrical impedance tomography, is if you do a recruitment maneuver and you set the first cursor position to the baseline and the second cursor position you set directly at the top of this recruitment maneuver, you can see that at the baseline you had very little ventilation here in the dorsal part. Basically only 2% of the ventilation was taking place in this dorsal region. During the recruitment maneuver, which means the PEEP was increased from 5 to 15, you see that now you gained 15% of ventilation in the dorsal part. So I would say this is kind of a very strong response in this example. Just to give you an example how differently from the same patient population with the same increase of PEEP data can look like, look at this. So here we have also just a very small dorsal ventilation of 5% at the baseline. But when you increase the PEEP from 7 to 16, it remained 5%. So nothing really changed in that patient. On the other hand, you see that because they also increased the driving pressure, you see actually an increase of ventilation, but it's happening in a region that was already ventilated at the baseline. So it's not really of any benefit. So that is a very easy way with EIT to identify how is the patient responding to a recruitment maneuver or any other kind of therapeutic measure. The second task which you can demonstrate in this data set is if you now follow the decremented PEEP. Now you have to set a new baseline. First we had the baseline before we did the recruitment maneuver. Now in this patient, and that was a responder, you can now define a new reference point at the highest PEEP level, where the lung is fully ventilated. So here we had a decrease of the driving pressure at the highest PEEP level, but still we had 11% of ventilation. And when you go down now and compare the PEEP level of 14 with the PEEP level of 12, this differential image remains black, which means there's no substantial decrease of dorsal ventilation. However, if you go further down with a PEEP level to 10 and compare now 14 against 10, then you start to see these kind of orange spots. And if you now look on these percentages, you see that the dorsal ventilation already decreased from 11 down to 5. So that is, in this example, the PEEP level where you see the first substantial decrease of dorsal ventilation. Needless to say, if you go further down to PEEP level of 8, I think that was a PEEP level of 8, and remember, that was a compliance, that was a point where they identified the best compliance for this patient. There you can see that you have already lost almost all the ventilation in the dorsal part. So as Ola has pointed out in his graph, the effect of the recruitment maneuver, and they were lucky to have a responder to that. It was already gone when they went down with the PEEP down to 8, where they observed the first decrease of compliance at a PEEP level of 6. That's why they try to reopen the lung and to set it to 8. So what applies to, you know, big studies about high PEEP versus low PEEP, the same is also true when you, for example, discuss the effects of recruitment maneuvers. You know, if you don't have the feedback, if you have opened the lung with a specific recruitment maneuver, then of course it's really hard to demonstrate the benefits of any recruitment maneuver. And the last thing, I know I'm already a little bit late, but I also started later, so I think I have another 2 minutes. You can also do it the other way around to illustrate the effects of, I don't know if I should call it overdistension, because I don't know exactly what overdistension means and if there's actually a step or a limit where you start to call it overdistension. So let's cut this away and say estimating the decrease of ventral compliance towards higher PEEP levels. That must have something to do with overdistension, I guess. So in order to do that, that's the last example I present you right now. You can set a new reference point now to the lowest PEEP level, assuming that at the lowest PEEP level you probably don't have any kind of overdistension. And then you can go the other way up again and take the second cursor, put it to a position of 8, and then you can see in the ventral part that you have no drop of ventral ventilation. Yeah? Because you could expect, if you overinflate the lung significantly, there should be a point somewhere where you start losing compliance in the ventral parts. If you now go down or go up with the second cursor position, which is now representing the higher PEEP, if you go, no, sorry, that was the wrong way. Okay, now we're comparing the PEEP level of 6 against 10. So you still see no orange spots here in the ventral part. However, if you go further up, then you see that you're starting losing ventilation, at least in the mid-dorsal and mid-ventral parts, which I would say is not really harmful, because even at this higher PEEP, which is of course causing a little reduction of compliance, this part is still properly ventilated. So, and I mean, just by comparing these two images, I think it's obvious that the ventilation distribution at this PEEP level of 12 is much more homogeneous compared to the PEEP level of 6. Okay, so to conclude on this part, I think electrical impedance tomography and our new device helps assessing the patient's response when you do recruitment maneuvers, PEEP trials, but also it's capable of displaying the effect of changes of the ventilator mode, for example going from SIMV ventilation to APRV. Unfortunately, we do not have a lot of data on that, but I'm sure we will see these data pretty soon. And but you could also assess ventilation and compare the effects of prone positioning, lung suction, and bronchoscopy. Thank you very much. I think we still have some time for a few questions.
Other questions?
Yes, please.
If not, we would.
Well, we have a question.
So about the technique.
Yeah.
So if I understand it correctly, all these values are relative values.
Yes. Yeah.
So there are no data from the respirator, volume of pressure data from the respirator.
No, it can actually be used without any connection to a ventilator or flow meter. It's based on the fact that the increase of impedance is quite linear to the increase of lung volume.